Hello and welcome to another live emergency questions and answers for families in intensive care and intensive care at home. Welcome to the show. I'm your host, Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. Thank you for joining the live stream, and also thank you for watching the show on replay, because I know there's always a lot of people watching this on replay, even though I encourage you to come on live to the show, because then you can talk to me directly and get your questions answered directly. In any case, we will be going for approximately an hour. I always do these YouTube lives for about an hour. That's a good opportunity for you to ask your questions, talk to me directly, or type your questions in the chat pad, or it's also a good opportunity for me to answer some of the emails that have come in during the week, and provide a service that is much needed for the community. Now, what makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? My name, once again, is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. I am a critical care nurse by background. I have been working in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can very confidently say that we have saved many lives with our consulting and advocacy. And that is documented on our testimonial section at intensivecarehotline.com. And it's also documented on our intensivecarehotline.com podcast section, where we have done client interviews. So I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. We also have a membership for families of critically ill patients in intensive care. We also do medical record reviews in real time. We also do medical record reviews after intensive care. With intensive care at home, we are currently sending our critical care nurses into the home 24 hours a day. We're providing a genuine alternative to a long-term stay in intensive care. Basically, we're bringing the intensive care into your home. And that means, we are providing intensive care at home services to adults and children with tracheostomy and ventilation, home BiPAP, home CPAP without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium, home IV magnesium infusions, IV antibiotics, central line, peak line, Hickman's line, as well as port management at home. We're also providing patch tube management at home. We're using cough assist machine. We're proficient with cough assist machines. We're also providing palliative care services at home. So we're also providing NDIS level 2 and level 3 specialist support coordination, as well as TAC and WorkSafe case management. We're also approved for TAC in Victoria, TAC and WorkSafe in Victoria, ICARE in New South Wales, and IISQ in Queensland, and also the DVA all around the country. Now, without further ado, let's look at some questions that have come in during the week from our readers and subscribers and from our clients. We get a lot of that every week, and let's start with some of them. So, first question comes in from Shelley, who says, "Hi Patrick, my husband suffered a massive heart attack 23 days ago. He was resuscitated and sent to Amarillo in Texas to a trauma center hospital. He was intubated and put on the ventilator. He's done really well. They attempted to wean him and take him off about 6 days later, to where he started panicking. his blood pressure dropped, and they re-intubated him. After all of this, I signed consent forms to have drain tubes put in because he had developed a pneumonia. These consent forms were signed on Monday, March the 3rd. They were not placed in him until Friday, March the 6th. So I assume Shelley is referring to the chest drains. Then they did a tracheostomy on the 7th, and then he had a PEG tube inserted the next day. The plans were to have the drain tubes placed either on March the 3rd, that night, or the next day on March the 4th, early AM. He had problems breathing even while on the ventilator. Now they're telling me he has infections, and they're not doing anything that I think is helping him. He's laying there, and they're not telling me what they waited for to do these procedures, i.e. chest drains, but I feel like this is doing more harm than good. They're talking now about sending him to an LTAC hospital. I don't feel comfortable about this. I don't feel like he got the proper ICU care. I believe he was neglected. Please help. Okay. Thank you, Shelley, for sending this in. Let's break this down one by one. So, had a heart attack. He was intubated and he was put on the ventilator. So he had some form of cardiac event from the heart attack that probably led him to become unconscious, or where he needed resuscitation from a ventilation point of view. Maybe his heart could no longer cope with the fluids, and therefore he needed intubation. They attempted to wean him and take him off. About 6 days later, to where he started panicking, his blood pressure dropped, and they re-intubated him. Now, given that he potentially has a pneumonia, I'm not surprised they had to re-intubate him. On top of that, you are talking about they're wanting to put chest drains in, which means he probably has some form of pleural effusion, which means fluid accumulation in the peripheries of his lungs or in his lungs, right? With those pleural effusions and the pneumonia, his lungs would become increasingly stiff, right, making it difficult for him to breathe, which is also something you are referring to in your email, right? So, with the pneumonia and the pleural effusions, of course, there's a much higher risk that he needs to be reintubated. There's a much higher risk that he needs ventilation, mechanical ventilation, right? There's a much higher risk, of course, he needs a chest drain, and any delays would make it more difficult for him to breathe, right? Very simple. So, you signed the consent forms, but the tubes were not placed in him until 3 days later. That doesn't make a lot of sense, because he would have needed the tubes early on. He might have even needed them before he got reintubated, because by draining the pleural effusions, his lungs may have increased their mobility, i.e., there would have been a lot of lung resistance, and the compliance of the lungs would have been down, right, because of fluid accumulation in the lungs. So you could argue there was neglect there, but in order to determine that, we would need to look at the medical records in much detail. It's also a fair assumption that if the chest drains would have gone in on time, and they would have drained the pleural effusions and avoided reintubation, that he may not have needed the tracheostomy, right? So picture this. Having someone ventilated with a breathing tube in ICU and being extubated is the best case scenario. That means someone goes from intubation, needing mechanical ventilation, to extubation, breathing spontaneously, breathing normally, hopefully leaving ICU as quickly as possible. Put that into contrast with a patient needing a tracheostomy, right? Basically changing the breathing tube from a breathing tube in the nose or in the mouth to a tracheostomy in the neck, attaching the ventilator there. Now, there's lots of complications coming out of that. There could be prolonged ventilation weaning. There could be a higher risk of a ventilator-associated pneumonia, right? There could be a higher risk of infections around the tracheostomy side, right? It's an unstable airway at the end of the day, right? And one could argue that with the delay of putting the chest drains in, intubation was necessary and tracheostomy came out of that. Now, on top of that, with the pneumonia, what are they doing? Are they giving him antibiotics if it's a bacterial pneumonia? Are they giving him antivirals if it's a viral pneumonia? Are they giving him antifungals if it's a fungal pneumonia? Have they sent the sputum samples to determine what sort of infection it is? Right? Next, you're saying he had problems breathing even while on the ventilator. Well, from my extensive experience, that's probably because, out of two things, because the pleural effusions haven't been drained, and that might have been contributing to making it difficult for your husband to breathe. That's number one. Number two, maybe he's too awake and fights the ventilator. That might be another reason. So the question is he on sedatives? Is he on opiates? Does he even need them? You know, if he's fighting the ventilator, I probably need something. The other question is, what do chest x-rays or CT scans of the chest show? You would see in a CT x-ray or in a CT chest or in a chest x-ray where the pleural effusions are and what needs to happen next. Next. With the issues in ventilating your husband, what are arterial blood gases like? What do the numbers show? Right? What's his PO2 like? What's his CO2 like? Right? So you're saying he's laying there and they're not telling me why they waited to do these procedures, but I feel like this has done more harm than good. Yeah, I agree with that. But in order to get the evidence and stop speculating, we need to get access to the medical records because everything else is speculation. There could be other things happening here that we don't know, that we will only find out by you and me either talking to the doctors and nurses directly or by me and my team looking at the medical records. In terms of your husband going to an LTAC hospital, I am very opposed to that. And I have made countless videos about why I am opposed to that. I have made a video here on YouTube Live as well, 10 reasons why LTACs in the United States are a scam. And I encourage you to check out that video because everything that you need to know about the LTACs are in that video. And everything that you need to know why your husband should not go to an LTAC is there. Right? So keep that in mind. And also, I don't understand why you have given consent to a tracheostomy so fast and why you have given consent to a PEG tube so fast, because it sounds to me like it's been 6 days since re-intubation. Now, if you look at the research and if you look at some of my videos and other content creators' videos or blog posts, a tracheostomy should be done after day 10 to day 14 after intubation and the inability to wean off the ventilator, right? That's when a tracheostomy should be done. I argue you should have definitely not given consent to a PEG tube, right? You should have not given consent to a PEG tube. Not at all. Why not? Simple reason is, and what I'm saying now is specific to the US, so this is particularly important for our US audience. In the US, if someone in ICU has a tracheostomy and a PEG tube, they are hemodynamically stable and otherwise stable, LTAC hospitals will take them. Now, that doesn't mean that those patients are ready to go to LTAC. Not at all. They're not ready. And I will elaborate on that in a minute. However, what you need to know for now is that if you could give consent to a tracheostomy and a PEG tube, and LTAC will take them, assuming they're hemodynamically unstable, they're not on inotropes, right? They're not on vasopressors, and so forth. Now, once again, nothing could be further from the truth. By you not giving consent to a PEG tube, and by you leaving a nasogastric tube in place for your loved one or for your husband in this situation, will suffice. It will absolutely suffice. And here are the reasons why, right? A nasogastric tube is safe as long as critical care nurses do the daily checks, look after the tube. With intensive care at home, for example, we are looking after clients at home with a nasogastric tube. So, if you can look after nasogastric tubes at home with critical care nurses, why can they not be looked after in an LTAC facility? Well, I have the answer to that, and I'll come to the answer in a minute, right? Well, no, let's get to the answer now. The reason is that LTACs simply do not have the skills to look after a nasogastric tube. It's probably more difficult to look after a nasogastric tube than a PEG tube, because the nasogastric tube is more likely to migrate, but it is not requiring a surgical procedure to do a nasogastric tube, whereas to do a PEG tube requires a surgical procedure. Why would you give consent to a surgical procedure if it's not necessary? What's the hurry to do a PEG tube if a nasogastric tube will suffice? Well, I can tell you why they want to do a nasogastric tube, and why they want to do a PEG tube. Well, number one, they want to make some money because it's a surgical procedure. And number two, once again, they want to send your husband to an LTAC as quickly as possible. Now, I can almost assure you that if your husband has not been looked after by a cardiologist as part of his ICU admission there, if he has not been looked after by all the specialists that need to be looked at, pulmonology, cardiology, potentially neurology, depending on whether there was some form of hypoxic brain injury, I can assure you, I can guarantee you, your husband will go to LTAC and will bounce back to ICU within 24 to 48 hours. I've seen it over and over and over and over again. Right? Now, two things that come out of that. Number one, LTACs do not have the skills or the expertise to look after your husband or anybody else in a similar situation. That's number one. Number two, God forbid your husband goes to LTAC, he will bounce back into ICU, and he will bounce back into an ICU that does not know your husband. Right? Once again, I've seen that over and over and over and over again as well. What does your husband need? And what do other patients in similar situations need? They need stability. They need a team around them that gets to know them as a person as well, so they know what they respond well to. And they don't need to be shifted around from hospital to hospital with different teams. That's insanity. That is insanity. Right? A critically ill patient in a situation like that needs stability, not being shifted around from hospital to hospital to hospital. So, where to from here, Shelley? Clearly, the husband needs stability, which he can probably only get where he's currently at. But I also understand that the trust has gone and that you feel like he's being neglected, right? Which is obviously a massive concern. But we can only find out about the neglect once you have access to the medical records, and we can look at it in fine detail and go through it with a comb, and break it all apart. So, lesson here. get advice early on. Get advice early on if you had engaged us, and get access to the medical records as early as possible. Because if you're not doing that, if we had worked with you by the time they were talking about the chest strains, and we would have looked at x-rays, we would have looked at CT scans, we would have looked at blood results, because that all ties in with pleural effusions, right, or ultrasounds they've done. We would have most likely prevented the negligence. We would have prevented the negligence, no doubt. Right? So, I hope, Shelley, that answers your question. Then, let's look at another question that has come in from Winnie. Winnie says, "Hi, Patrick. My father is in ICU and has been there for a few days with a pneumonia." And she says, "They're wanting to withdraw life support tomorrow because he's not a candidate for a tracheostomy. All his vitals are stable, but he's not alert enough to protect his own airway. I have pictures of the ventilator settings." Now, Winnie, that's an unbelievable case, right? But it's also one of the cases where we can help, because that's actually our specialty, to turn situations like that around. And this is when I keep referring to that we have saved many lives. These are situations we've seen over and over and over again, and we do actually know how to turn these situations around. And I'm not exaggerating here, because it's documented in our testimonial section, and we have interviews around those situations on our podcast. So very positive that we can turn this situation around and let your dad live and have a tracheostomy. Now, here is another thing that I am constantly gobsmacked about. What I don't understand here, Win, is that you just get on with it. What do you mean when you're saying they're wanting to withdraw life support tomorrow without your or your father's consent? You have not shared what your father's conscious state is like, whether he's in an induced coma, whether he's awake. You haven't shared any of it. But now, I tell you something. Removing life support without consent could be perceived as euthanasia. It could also be perceived as murder. Right? The other thing here is, what's the hurry to kill someone? Where's the rush? Where is the rush to kill someone? I've yet to find out. I've yet to find out where there's the rush to end someone's life. And that is the question you should be asking the intensive care team there. Why are they in a hurry to kill your dad? Why can't they do a tracheostomy? Right? If he's not alert enough to protect his own airway, he needs a tracheostomy. Right? Can you actually verify that he's not alert enough to protect his own airway? Also, if he's not alert enough to protect his own airway, and if he's not alert enough in general, why are they not moving heaven and earth to try and wake him up, talk to him, and let him make his own decision about his own life? That is a very cowardice approach. Trying to kill someone without consent from either the patient or the family. That's very cowardice. And where's the rush? Now, you or some of you watching this might have heard me talk about real versus perceived end-of-life situations. What's the difference? I'm glad you've asked. A real end-of-life situation is a situation in intensive care where nothing, and I mean nothing, no surgery, no medication, no fancy equipment, no resources can save your loved one's life. That's a real end-of-life situation. Now, if someone is actively withdrawing treatment from your dad, that is a perceived end-of-life situation. The perception is, well, we might as well let him die. That is terrible. That is absolutely terrible, and it's absolutely shocking that this is happening in 2025, right? It is absolutely shocking. So what do you need to do? What you need to do is make a complaint now. Don't wait. Write to hospital executive. We can help you write a letter. Like I said, we have turned many of those situations around. I can assure you that pretty much all jurisdictions have laws around protecting lives, right? Hospitals and ICUs in particular are very good to pretend they can do whatever they want. Nothing could be further from the truth. Now, they will try and intimidate you, and they will pretend they can do whatever they want. Like I said, nothing could be further from the truth. The minute you challenge them, you will see they will retreat. They will back off. But it doesn't sound to me like you've challenged them, and you haven't challenged them enough. One other way to approach it is to ask them to access medical records so you can seek a second opinion. Very important point to make. Very important for you to, make that point. Next, hospitals operate with policies and procedures. What does that mean? Everything in a hospital has policies and procedures. Mopping the floor, washing the window has a policy and procedure. Open heart surgery, brain surgery, you name it, has policies and procedures. Treatment in intensive care has policies and procedures. So what does that mean? Because there's policies, procedures everywhere, end of life has policies and procedures, which are embedded in the laws in the jurisdiction around it, which means the law can't say, oh, a patient can only be removed from life support if there's consent from a patient or a family, right? If that's what the law says, and I can guarantee you that is what the law says, then the hospital policy will also say that consent must be sought. And judging from your email, Winnie, no consent has been sought here from anyone. Right? So as a matter of urgency, write to hospital executive, potentially go to your local court, go to your local Supreme Court, seek an injunction, which we've done successfully for a number of clients, with the help with the lawyer. But they still need the clinical evidence which we can provide, right? So that would be my very strong advice here, Winnie. Don't let them walk all over you, right? Also, keep in mind, approximately 90% of intensive care patients survive, right? So why would your dad be 1 out of 10 not surviving if the odds are in your dad's favor? And they are, right? They are. Next, there's no guarantee that your dad will actually die when they remove life support. Now, once again, I don't know the ins and outs. He might be on other forms of life support. He might be on inotropes. He might be on vasopressors. He might be on dialysis. We don't know. And he might die. He might not. Right? So it might be an inaccurate prediction that your dad is going to die if they extubate him. Okay, let's move on to the next question from Spencer, who says, I'm frustrated because my mom needs prolonged intubation. So let's clarify, what does prolonged intubation mean? Prolonged intubation means if someone is ventilated with a breathing tube for over, let's just say, 10 days. Why is the 10-day mark so important? Well, I just mentioned it in one of the emails. Why the 10-day mark is so important. The 10-day mark is so important because 10 to 14 days of intubation and the inability to wean a tracheostomy might be needed. If a tracheostomy is needed, right, then, you know, that's fair enough, but leading up to it, what is the intensive care team doing to help your loved one in intensive care to wean off the ventilator and avoid the tracheostomy beyond the shadow of a doubt? That is a question you need to ask, right? In the meantime, are they stopping sedation? Are they taking off opiates? Are they doing spontaneous breathing trials? Are they doing physical therapy? Are they mobilizing your mom? Are they changing ventilator settings, and do spontaneous breathing trials? What are your mom's arterial blood gases? What are your mom's chest x-rays, right? Those are questions you need to ask. And you need to ask them urgently, right? If your mom, when you say, you're saying prolonged intubation, it's not clear in your email what it means, but if your mom is intubated for prolonged periods, let's just say she's been intubated now for 20 days, for 15 days, for 25 days, and she can't come off the ventilator, she has shown she can't be off the ventilator for whatever reason, she needs a tracheostomy right now. I can guarantee you that. You can see that the devil is in the detail, right? You can see that the devil is in the detail. Okay, let's move on. Helene, welcome to the show. Nice to see you again. You're saying at Wellstar Atlanta Medical Center South in 2016, they refused to give me their policies and procedures. Now, I don't know the ins and outs. What I do argue is, if you are the medical power of attorney, which I believe you were at the time, they have to give you access to the medical records, right? So that much I will say here without knowing all the details. Okay, so let's move on to the next question from Pedo says, hi Patrick, my dad will still need to have a tracheostomy and feeding tube, and we will have to place him in long-term rehabilitation LTAC to get better. The ICU isn't wanting him to heal, so he needs to be elsewhere to get healed. Well, once again, I don't know your dad's exact situation. However, you are going along with a hospital narrative here. Do you think that going on with the hospital narrative so far has served you? Right? Why does he need a tracheostomy? Why does he need a PEG tube? Like I explained earlier, a tracheostomy might have its time and its place if your dad has shown he can't be weaned off the ventilator. If there's any sign that your dad can be weaned off a ventilator within a reasonably short period of time, he may be able to avoid the tracheostomy. Now, one thing that I can assure you is you can definitely avoid the feeding tube. A PEG tube is only really needed when a patient is never going to come off the ventilator and the breathing, the ventilator, right? Needs ventilation for the rest of their lives, or they need ventilation for the rest of their lives. They can't swallow, they can't cough. You know, that's when a PEG tube then is needed, right? If a tracheostomy or ventilation is needed for the rest of their lives. That is the only time really when a PEG tube is inevitable. But most patients do not need a PEG tube in the long run, right? So you are pretty safe there that you do not need a PEG tube in the long run. I can guarantee you that. Helen, you are saying they gave your mom lethal amounts of propofol to force her to be trached and ventilated. Yeah, that is very sad if that was the case, and I hope you can bring the people that have done this to justice. You know, coming back to John's email where he says, my dad will still need to have a tracheostomy and feeding tube, and we will have to place him in long-term acute care facility to get him better. Well, that's the hospital narrative. Whilst I understand you probably want out of this ICU, you might actually go from bad to worse. I've seen it many times where patients go from ICU to an LTAC in the US. LTACs are unique to the US, right? And things go from bad to worse. Have a look at the LTAC reviews online in your area, but have a look at the LTAC reviews around the country. Have a look at them online. We would have some interviews on our blog, on our podcast, where we've done some interviews with families who had their loved ones in LTAC. They are horror stories. Now, if ICU isn't wanting him to heal, that is obviously a concern. Maybe you need to look at a discharge to another ICU. Right? That is what you may need to do. But one thing that families in intensive care also don't understand is you have to create your own narrative. And we've done this many, many times where, you know, the narrative goes from the narrative goes from you know, you need to go to LTAC to, well, let's wean off the ventilator and the tracheostomy in ICU. Right? You need to change the narrative. It's very simple. You know, once again, there's an interview on our podcast with a lady called Whitney, how we avoided LTAC for her mom and how she got weaned off the ventilator in ICU. Right? You know, very simple, very simple. Okay, let's move on to the next question. Let's move on to the next question. If you have any questions, type them into the chat pad or connect with me live on the StreamYard link, which I post in, forgot to post that earlier. So, okay, let's move on to the next question. Okay, here's an email from Isaac who says, "Hi Patrick, I'm reaching out to you in regards to my mother who has been in ICU." Oh, hang on. Before I read that out, Helene, you're saying, I have to file a police report against multiple doctors and hospitals. I am challenged in what to write or try again to hire an attorney. I have to file a police report against multiple doctors and hospitals. I am challenging what to write or try again to hire an attorney. Well, one thing that I would recommend there, Helene, is we can look at the medical records, and we can provide the evidence where the medical negligence has been, that you can then present to a lawyer. We are finding that lawyers have no idea how to extract the right clinical information from ICU medical records. That requires ICU doctors, ICU nurses to look at medical records, which we actually have access to. Most lawyers and attorneys do not have access to ICU nurses or ICU doctors reviewing medical records. Right? So have a think about that. Send me an email if you want to, if you want us to have a look at the medical records, so you can get closure and bring the right people to justice. So next email from Isaac who says, "Hi Patrick, I'm reaching out to you in regards to my mother who has been in ICU for about 5 days now due to a hypoxic brain injury from a cardiac arrest. Since it's been 5 days, the doctors want us to make a decision by tomorrow or Monday about my mother getting a tracheostomy. I wanted to do a 60-minute Zoom consultation with you so my family can make the right decision. Of course, you can book a 60-minute Zoom call with me. You can book a time with me on the website through our products page, where all the prices are for a 60-minute Zoom consultation. Now, this is not dissimilar to some of the cases we discussed already. 5 days in ICU on a ventilator after hypoxic brain injury and mechanical ventilation. It's too early to do a tracheostomy. Too early to do a tracheostomy, right? Way too early, as a matter of fact. Again, they are trying to create a narrative to you. What you haven't mentioned is that they want to do a tracheostomy. Do they want to do a PEG tube as well? Right? Do they want to do a PEG tube as well? And after everything I've shared today with other case studies, the answer is you should not give consent to a PEG tube. Now, once again, tracheostomies might have their time and their place. So does a PEG tube. But 5 days in ICU, not a long enough time. Here are the questions you need to explore. Why is she not waking up? Is it the hypoxic brain injury, or is she still on sedatives or opiates? Is she having seizures? Have they done cooling therapy? Right? What are they doing to avoid the tracheostomy? What are they doing to avoid tracheostomy? Right? What are they doing to avoid tracheostomy? That's the biggest question. Right? If you want to send me an email, send it to this email address here. I'll just post that into the chat pad. Just send it here. All right. So, but coming back to Isaac's email, Have you spoken to a neurologist? Have you spoken to a pulmonologist? You need to talk to the pulmonologist about her chances to wean off the ventilator and avoid the tracheostomy. You got to speak to a neurologist. What are her chances to wake up? Is she having seizures? Are they giving any anti-seizure medications? What do CT scans of the brain show? What do MRI scans of the brain show? Right? Those are the questions. Have you asked those questions? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And it's very easy for you to make the wrong decision prematurely because of hospital and ICU teams creating narratives that are not in the best interest for your family member. Right? Are those decisions in the best interest for your mother, or are they in the best interest of hospital goals, ICU team goals? That is really the question that you need to ask here. You know, you have to think critically here. You have to think very critically here. Right? Let me repeat that one more time. The goal must be for your mum to avoid a tracheostomy and get off that ventilator and the breathing tube. It may not be possible, but that's too early to determine after 5 days in ICU. Not a long enough time. Not a long enough time frame. Okay, so let's move on to the next question from Fatima, who says, "Hi Patrick. Can you answer my question? My husband has been in ICU since last Monday. His pancreas has caused an infection in his body. He was on a ventilator for 3 days. Then he came out of the ventilator. He looks very confused, but does remember me. They are giving him the best antibiotics. My question is, how long will it take for him to get better?" Right. Okay. So I assume he's got pancreatitis, which is an infection of the pancreas. Probably was in septic shock or in sepsis. That's probably why he needed to be ventilated, right? Not surprised that he's confused after 3 days on the ventilator and in an induced coma. No surprises there. It's good that he's come off the ventilator. Let's keep it that way. Let's get him out of bed. Let's do some deep breathing and some coughing exercises, whilst he probably needs to have some pain control, because pancreatitis can be very painful, right? The question here is not so much are they giving him the best antibiotics, the question is, are they giving him the right antibiotics? So what do I mean by that? The right antibiotics means that they're targeting the right bacterium, right? So whatever has caused the pancreatitis, whatever bacteria is growing there, the right antibiotic needs to be used to treat the bacteria. So how long will it take for him to get better? Now, the confusion that you're describing here, and potentially agitation, might last a few days, maybe even a few weeks. Now, the quicker he can get out of ICU and can get back to normality, the better. What do I mean by that? He's probably stuck in an ICU with little or no natural daylight. There's a lot of noise around him, you know, people talking all day, 24 hours a day, lights on, lights off, and so forth. Now, get him back to normality as quickly as possible. What I mean by that, like I said, get him out of bed, get him to a shower, make sure he gets good nursing care, you know, gets looked after really well. that he's getting showers, washes, skin care, mouth care, all of that. If he can't mobilize yet, make sure he's getting regular turns so he's not developing any pressure sores. Someone is taking care of his physical needs, while he's potentially immobile. Next, more than likely, he is nil by mouth. So that means he can't take anything orally to protect the pancreas. And more likely than not, he is on TPN, total parenteral nutrition, or IV nutrition, or at least on partial PN, right? He might also be on a dextrose infusion and insulin infusion, because what if the pancreas is infected? The pancreas may have stopped to produce enough insulin, right? The question is also, what was the cause of the pancreatitis? Was it gallstones, or was it, potentially alcohol abuse? Could be caused by either any liver issues. Let's reverse the cause as well, right? So, in terms of the confusion, that might also be treated with other medications in ICU, right? To avoid ICU delirium, to avoid ICU psychosis. You're trying to avoid that. But some medications that could be used for that are haloperidol, olanzapine, quetiapine, but it's not ideal. It's not ideal. It's much better to go to a hospital ward, with your own room, assuming your husband gets better and is ready to leave intensive care, But the most important part is here to get back to normality as quickly as possible. Other treatment options for pancreatitis, of course, is IV fluids, to maintain blood pressure and organ perfusion, because your husband can't have anything to eat. He would have a nasogastric tube, but very unlikely that he would get any food via the nasogastric tube, right? He also needs IV opiates such as morphine, fentanyl, hydromorph to control severe pain, like I said. Mild oral intake can be resumed, or nasogastric tube feeds can be resumed as soon as possible. If severe enteral nutrition via nasogastric tube or via nasovaginal tube is preferred over total parenteral nutrition, TPN, to reduce the infection risk, but very unlikely if it's a severe form of pancreatitis that's going to happen. It will be TPN. It's good that your husband is off the ventilator, because some pancreatitis patients do develop ARDS, acute respiratory distress syndrome, also known as lung failure, and may need oxygen therapy or mechanical ventilation. So that is really good that your husband is off the ventilator. Vasopressor or inotrope support may be needed if fluids alone don't maintain the blood pressure, because of the septic picture. And because of the septic picture, your husband could also go into kidney failure. Then he may need dialysis or hemofiltration. Once again, what are reversible causes? Gallstones, right? Does he need to have them removed? Like I said, alcohol-induced, or does he have hypertriglyceridemia or hypercalcemia? And that's also where the insulin and glucose infusion come in. The danger is here that the pancreas is necrotizing, because then also, if necrosis becomes infected or leads to sepsis, a minimally invasive drainage or surgical debridement even may be needed. What's the prognosis? Mild cases improve within a few days with supportive care, and severe cases can lead to multi-organ failure requiring prolonged ICU stays. It sounds to me like your husband is on the mend, and that's a good thing. and hopefully the confusion can be overcome. Okay, hopefully the confusion can be overcome. So, I am going to wrap this up in a few minutes, right, in a couple of minutes. If you have any last questions, type them into the chat pad. If not, I will wrap this up in a couple of minutes. I do these YouTube lives every Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 7:30 p.m. on a Saturday night Eastern Standard Time in the US, and that is 4:30 p.m. on a Saturday afternoon Pacific Time, which is 6:30 p.m. Central Time, 5:30 p.m. Mountain Time, and I believe right now it is just after midnight in the UK. Those are the times. They will change slightly in April when we finish daylight saving here on the East Coast in Australia. That means the times will be slightly earlier for our US audience. It'll be 6:30 p.m. on a Saturday evening on the East Coast Eastern Standard Time, but that won't be until the first Sunday in April. Okay, so Helene, you're saying, lastly, true. For the right antibiotic to prevent superbugs, I discovered that mom was being prescribed the wrong antibiotic for UTI infections, nor were they willing to confirm it had been cleared up. Right. Right. Bear in mind, Helene, sometimes they might start a broadband antibiotic until they found the right bacterium. Right? So just to keep that in mind as well. Okay, I'm going to wrap this up in a minute. If you need help because you have a family member in ICU, go to intensivecarehotline.com. You can get more information there. Also, if you like the work that I'm doing, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, comment below what you want to see next. Share this video with anyone that has a loved one in intensive care. Like I said, if you need help for a family member in intensive care, go to intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. If you need intensive care at home, go to intensivecareathome.com. Like I said, with intensive care at home, we are operating all around Australia and all major capital cities. We are, and all regional and rural areas where NDA is approved. THC in Victoria, WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, and DVA all around the country. We're also providing level 2 and level 3 NDI support coordination. Once again, thank you for your support and thank you for watching, and also thank you for those watching on replay. I wish you and your families all the best. Have a wonderful rest on the good rest of the weekend, and I'll talk to you again next week and during the week with my quick tip updates. Take care for now.